Okay, let's go ahead and get started again. Since we're down to the last hour, and we still unfortunately have a lot of stuff to cover, but we're getting through it. It's a big lecture today. Okay, so I want to go ahead and just talk about the bronchodilators. Okay, so we have the sympathomimetic bronchodilators, right? And within the sympathomimetic, I have a few different groups. I have my catecholamines, right? My catecholamines, that's one group. What else do I have? My ressorinols, right? That's a second group. And then my third group, my saligenins. Okay? So my catecholamines, what do I have there? Well, I have things like epinephrine, norepinephrine, and so on. Okay? Ressorinols, what types of medications do I have in that group? Well, terbutaline. Okay, what else? Metoprolol or Albuterol. Okay, little longer duration action, right around 4 to 6 hours. These are right around 1 to 3 hours. Okay. And then my saligenins, and these will include things like Albuterol, Xopenex. Okay, 4 to 6 hours. More beta 2, less beta 1. Everyone's okay there? Okay, so those are my under the sympathetic. I just want to go ahead and talk about the doses real quick. And you guys can understand why I'm having you do drug cards now, just as a way of going over the doses one more time. Yet again, you always have them. Okay, so let's talk about racemic epi first of all. So racemic epi, okay. So we give that by small volume nebulizer. The general concentration we run into is 2.5%. Okay, and we give 0.25 to 0.5 milliliters. Okay, and the standard dose is about 5.63 to 11.6, is it? 11.25, excuse me, 11.25 milligrams. Okay, so that's racemic epinephrine. I'll leave this up here. Albuterol. Okay, we can give it by small volume neb. We can give it by MDI as well. Those are two common. There are different concentrations, right? There's 0.5% and 0.083%. Okay, the two common concentrations. The milliliters, the number of milliliters that we're going to give will vary according to whatever our percentage is. What's the standard dose for albuterol? 2.5 to 5 milligrams. 2.5 to 5 milligrams, standard dose. If we're talking about an MDI, it's 2 to 4 puffs. And we can give that TID, sometimes QID, 3 to 4 times. Sometimes they'll even give it every 4 hours. So there are lots of different ways that we can give it. Okay, Xopenex. What is Xopenex, first of all? Is there something special about Xopenex?
It's like albuterol but with less cardiac effects.
Okay, so does albuterol normally come in a racemic mixture? What do you guys think? Yes or no? Albuterol, is it a racemic medication? It is. It is a racemic medication. There are two forms of albuterol. There is the right-handed form and the left-handed form. Okay? Or what we call isomer. The D and the R isomer. Xopenex is all the R isomer. It's the isomer of albuterol that actually works. See, the normal albuterol that you give somebody has a mixture of the two types. The one type doesn't really work, doesn't do anything. In fact, Some people say it may actually be harmful. But it's a combination of something that works and something that doesn't. Xopenex, however, is concentration of the R isomer of albuterol. The R isomer. So in theory, it's supposed to have less beta-1 effects, and it's supposed to be more potent than albuterol. Okay, that's a theory. Generally, though, it works about the same. It's about as effective as albuterol. But sometimes you will see the cardiac patients will get Xopenex because the physicians are worried about cardiac effects of albuterol. Often we can give it by SVN. You also see it be given by MDI. Okay. The standard doses, there are different concentrations. The standard dose that we need to worry about, 0.63 to 1.25 milligrams. Okay, 0.63 to 1.25 milligrams. Often you'll see TID. And we know where we might want to choose Xopenex over albuterol. However, albuterol is cheaper. So often a lot of hospitals will go with albuterol, and they will have a system in place where even if the physician orders Xopenex, the hospital will still give the patient albuterol because it's cheaper. So sometimes what you'll see is you'll see the physician write an order for Xopenex, 1.25 milligrams TID, DNI. What do you think that means? Or DNS, sorry. There we go. Do not substitute. So what the physician is saying is, I don't care that the hospital likes albuterol. I do not want you to substitute Xopenex with albuterol. You give that patient Xopenex. Does that make sense? So when you see a DNS order on your patient, that tells them that, no, I know the hospital likes albuterol, but the physician specifically is telling me, I do not want you to substitute Xopenex with albuterol. Give the patient Xopenex. If they don't have that in the hospital substitutes, you may end up going ahead and substituting for albuterol. You may give 2.5 or 5 of albuterol. 2.5 is generally the standard dose. And then there is a salmeterol. That's often going to be a dry powder inhaler or a DPI. And the common dose that we see is 50 micrograms BID, right? Twice a day, or Q12 hours sometimes. Almost the same thing, BID, because it's a 12-hour duration of action, right? Twice a day. Okay, so those are the common medications and doses that I'm going to want you guys to know. And I'll go ahead and just leave this up here. Someone is asking about duration of action. I'm not going to focus too much on duration of action. However, I would take a look at the ultra-short-acting agents because sometimes you see those on tests. And just know that medications like albuterol are going to have a longer duration than pure catecholamines. Okay. So we'll go ahead and continue on. So side effects. Can we have side effects of these drugs occur? Yes. What do you think the common side effects are?
Increased heart rate.
Increased heart rate, tachycardia. What else? Hypertension. How about anxiety and tremors? Yes. Yes. Those are the major side effects that we can have. If somebody develops significant tachycardia, their heart rate, I believe they often will say, increases more than 20 beats a minute above the baseline, consider that a reaction. And, we may have to call a physician, let them know about it, monitor the patient very closely. No signal. Uh-oh. Did I lose something here? Okay. Well, looks like we do not have a signal anymore. Or a computer, for that fact. Okay, so we'll just keep on talking anyway. So anxiety, tremors, hypertension, elevated blood pressure. What about electrolyte problems? Did you guys read anything about electrolyte problems being a problem with bronchodilators? What do you guys think? Potassium. Somebody said it. And what happens to potassium? It drops. And that's called hypokalemia, or low potassium. I can get hypokalemia with a lot of the bronchodilator type medications. Hypokalemia. Okay. So let's go ahead and move on and talk about the parasympathetic medications, or the medications that block the parasympathetic nervous system. And what do we call that? When we block the parasympathetic nervous system, what do we call that? A parasympatholytic. Okay. Parasympatholytic? You guys good there? Okay, that blocks what? The parasympathetic nervous system. Now, the first kind of substance that we run across is something called atropine. Have you guys ever heard of atropine? Atropine. Okay. And kind of the history, it used to come from, it comes from a plant known as the Belladonna, or deadly nightshade. And I believe, let me go to my Greek history, Socrates, did they not make him kill himself by drinking? Yeah. Was it the Belladonna tea? He drank the tea. So what do you suppose had happened if somebody overdosed on this stuff? What do you guys think? Stops the heart? Do parasympatholytics stop the heart? No, they don't stop the heart. So what happens? Let's go through the pathophysiology. What's going to happen here? I'm going to block the parasympathetic nervous system. So what's going to take over now? Sympathetic. Increased heart rate. Increased blood pressure. What about my secretions? What's going to happen to my secretions? They're going to dry out. What will happen to my body temperature? It's going to increase. Okay. What about my pupils? Are they going to constrict, or they're going to dilate? Absolutely. Okay. Good. Good. So that is a parasympatholytic type of response that we can see. And can we see where that would potentially be helpful for our patient? Well, am I going to suppress bronchoconstriction if I suppress the parasympathetic nervous system? Because what does the parasympathetic nervous system cause? Dilation? Constriction. Yeah. And it also does what? Mucus production. So I'm going to dry my patients out as well. Now, do you, well, you probably don't know because you haven't been in clinicals yet, but we don't see a whole lot of patients getting atropine for respiratory disorders. We will see atropine given for certain types of bradycardia, but not necessarily respiratory disorders. So we actually have a derivative of the medication called Atrovent, or ipratropium. Ipratropium is the generic name. Atrovent is the trade name. Okay? So this is the most commonly used, Atrovent, or ipratropium. Most commonly used anticholinergic or parasympatholytic bronchodilator. Is it often used by itself, however? No. We will often give it with a bronchodilator. And when you guys did your drug cards, did you come across a certain type of medication called a duoneb? What is a duoneb? It's a combination. It's a combination of albuterol and Atrovent. And it's very common to give that. Aduoneb, albuterol and atropine combination. Hey, here we go. Back up again. Oh. Okay, so atropine, we talked about that a little bit. What it does, so ibupropium is just a derivative of atropine. Okay? Peak effect, 1 to 2 hours, so it takes a while to start working. Is this going to be a good rescue medication? No, it's not. You don't want to give it by itself. You can give it combined with something like albuterol, but you want to give a rescue medication. They do make long-acting anticholinergics. Spiriva is the one that you'll see used. It's not indicated as a rescue drug. None of your maintenance medications are indicated for rescuing patients. Okay, here's just a little table, doses, frequency. You don't have to focus on this as much. I would ask you to look at Atrovent, however, because Atrovent's the common one that you run across in clinicals. Monitoring outcome of bronchodilator therapy. Well, you guys just had your patient assessment lab, right?
Yeah.
So how will we monitor somebody that you just gave or you're giving a medication to, a bronchodilator? Their respiratory rate, heart rate, blood pressure, how about their lung sounds? Yes. Okay. So let me give you guys a trick question now. Let's say that a little kid comes into the emergency room, has a history of asthma, is having an asthma attack, and you listen to his lungs and you don't hear anything. They're just almost silent. You hear very little. Okay? And the physician goes, get that kid some albuterol. What do? You get that kid some albuterol. And then 15 minutes later, you listen to him, and you have wheezing everywhere. Massive amounts of wheezing. Like, wow, this kid is really wheezing. Has the patient gotten better, or have they gotten worse? You guys think? Better? Who says better? Raise your hand. Okay. Who says worse? Raise your hand. Who doesn't know? Okay. So initially, we didn't hear much of anything, right? We had very little air movement. Now we hear something. It's not a normal sound. It's a wheeze, so there's still bronchoconstriction, but at least I have air movement. So don't necessarily be fooled by that just because you hear wheezing, your patient is getting worse. Sometimes, if you don't hear much of anything, you give a treatment and now you hear wheezing, that means the patient's getting better. Yes, you may have to give them more albuterol or more medication, but you're having more air movement. You can hear more sounds. And that may indicate that the patient's actually getting better. And there's something called a silent chest, where you can have severe asthma or bronchospasm to the point where you can't hear any air movement at all. And obviously that's actually a very, very serious condition. You'd rather hear wheezes than that. So don't always be fooled by wheezes. Okay, ask them how they feel. Hey, how you feeling? Maybe they could only speak to you in 1 or 2 words. I feel bad. And now they're speaking to you in full sentences. They're improving. Pulse oximetry may or may not be helpful. PEFR, and we will talk about this a little later on. But this is something called peak flow. And we'll talk about this later on when we talk about asthma management and asthma action plans and having your patient do peak flows and teaching them peak flows. Just at this point, know that it is something that we assess for. You have the patient basically blow out over a second, and this is called the FEV1, or forced expiratory volume in 1 second, and we look at the PEFR, the peak expiratory flow rate. And it differs depending on how old you are, how tall you are, and whether you're male or female. And we'll talk about this stuff a little later on. Okay, yep. Okay, all the signs of improvement. Obviously, if their peak flows are increasing, that's a good thing. Their vital signs are improving. Their dyspnea is improving. Accessory muscles, they're not using as many accessory muscles, and so on and so forth. Okay, negative response. We talked about this. Heart rate greater than 20% of baseline or 20 beats a minute, significant. Stop the treatment. Monitor them. Talk to the physician. Document what goes on. Do we have to run to the nurse right away if we have a problem with the treatment? Do we run to the nurse and get orders from the nurse? No, right? No, seriously, this sometimes occurs, and you might even see questions about this. Who do we go to when we have problems?
Doctor.
We go to the physician. Do we let the nurse know, though? Yeah, sure, you can let the nurse know, but we don't go to the, and unfortunately, you're going to run into this in clinicals, where something will be going on with a patient, and the respiratory therapist will go, let's talk to the nurse about that and see what she wants to do or he wants to do. You'll see that. It's not right. You're going to see it. We are licensed practitioners, just like nurses. We have a license to practice respiratory medicine. And as such, we can take that responsibility and we can talk to the physician instead of, have the nurse call the doctor. You know what? No, you're a respiratory therapist. Get on the phone with the doctor. Tell them yourself what's going on. Take that responsibility, but it isn't necessarily always that way. That doesn't necessarily happen all the time. Okay, xanthines, the last group, finally, right? This has been a very ambitious day, a lot of information. The final group. Xanthines are caffeine-like, and sometimes we'll call these xanthine derivatives, found in some tea as well. The medication that you see represent this class is known as theophylline or aminophylline. Okay, these are the medications that we run into. Xanthines are thought to produce bronchodilation by inhibiting phosphodiesterase, which deactivates cyclic AMP. So if I inhibit the enzyme phosphodiesterase, I increase the amount of cyclic AMP, and that causes bronchodilation. That's traditionally what we thought. Although this is still thought to be true, we're finding that xanthines are not really great at inhibiting phosphodiesterase at the doses that we give. So something else must be going on. Bottom line, however, they are considered a weak bronchodilator. Maybe we're not quite right on their mechanism of action, but they're still considered weak bronchodilator. Non-bronchodilating effects. Unfortunately, we have lots of other effects occurring with our xanthine derivatives. They can increase the ventilatory drive. Metabolism occurs at different rates in different people. Can increase the strength and endurance of muscle contraction, the diaphragm. May help people stay out of respiratory failure. May, I say. The big problem that we run into with these medications is they metabolize at different rates in different people. So anybody on a xanthine or xanthine derivative, they need to get their blood drawn every so often. And we need to check the levels, the drug levels, the serum levels of theophylline. And sometimes you'll see that on a patient that comes into the hospital and they have a history of, say, COPD and they're on theophylline. One of the things the physician will order is, what's his theophylline level? Is it toxic? Is it too high? Or is it too low? And what's too high for one person may be too low for another person, and what's too low for one person may be too high for another person. There's a lot of variability in this. Patients can react to the xanthines very differently. So it's kind of a difficult medication to give. You're not going to see it used as much anymore. It still is used. It's used often as a maintenance or chronic medication. In patients that we've had lots of problems getting them controlled, and they may end up putting them on theophylline. Lots of side effects: dizziness, headache, restlessness, palpitations, arrhythmia, tachycardia. Well, we see that with a lot of our bronchodilators. Nausea, vomiting, diarrhea. Well, we can see that with just about anything. They can have really severe cardiovascular side effects, though, with toxicity. Theophylline toxicity is certainly no joke. It is a big deal if they get toxic on their theophylline. These are common xanthines. Theodur is really common. Again, theophylline is going to be the big generic, and there are lots of different brand names. And that's really all we're going to go into on the xanthines at this point, at least. Yeah, theophylline or aminophylline. These can be given IV as well. Okay, guys, we actually have a few minutes, so I'm more than happy to review anything you guys want. You guys that came in at 7:30 this morning, do you feel a little more comfortable with the math problems that we went over? Did that make a lot more sense? Oops. I don't know why I did that. A little off my game today, but okay, good. I can keep this up, or you guys got this copied, or you guys good to go here? Okay, good. No. All right. Okay, so let's just go ahead and make sure everybody's on the same page. I was getting lots of calls over the weekend about the homework. Yeah, it's not due till the 3rd, and it's on the syllabus.
It is, but a couple of weeks ago you had said it's due in 2 weeks, but which would have been. That's why.
Oh, okay. Maybe I did. I don't know. If I did, I apologize. But yeah, it's.
And then, do you have another homework they're giving us? Because
no.
on the. Okay.
No, this is it.
It's the Bronchodilators and drug cards.
They're both. It's all the same homework. Yeah, it's it. Yeah. So next week, let's make sure everybody's on the same page. Next week, your bronchodilator and drug card homework will be due, and everybody is able to access that on Blackboard. Download there are 2 sheets. You'll download them, and you'll do that. Some of the drug cards will have medications other than bronchodilators. You know, you're going to do things like Mucomist. Please go ahead and make sure you do all the drug cards that will be on that list. That will set you guys up to succeed as we hit all these other classes of medications. Okay, so we will have midterm coming up in October. So that'll be a very big exam. That'll be 25% of your grade. So a really big exam there. It will include all the information that we've covered up to this point. So all the information that you had on the first exam will be on the midterm. So you can expect to do more calculations and to have more questions about things like pharmacokinetics and dynamics. And so that stuff will be on the. It'll still be 20 questions though. Yeah, it will not be a long exam.
Any math?
Yes, there will be math. Yeah, there will be math on there. Yes.
Yeah, I'm just on the homework. I have the drug card and the bronchodilator homework, but I couldn't find that bronchodilator homework. Is that a sheet of something to work out?
Just drug card.
It's the drug card.
The drug card. That's it. Yeah.
Just the drug card.
Yeah, there are 2 sheets, and basically the other sheet is just a picture of like an example of a card. Yeah. That's it. So it's pretty easy. So what you do is you guys will hand those in to me. I'll make sure that you did them. I'll hand them back to you. Homework is actually a good portion of your grade too. It's about 6% per assignment. So the homework's a real nice, easy way to get lots of points. Any other questions over anything that we've done so far?